Well, good afternoon, everyone. It's a pleasure to be with you today. And I was going to say, it's, when you're announced as being associated with The Ohio State University, that always comes with some trepidation because you're not sure exactly how people are going to feel about that. And it reminds me, now being in Florida, how both elated I felt in 2006, I think it was, when I went out to Arizona to watch my Ohio State Buckeyes face off with the Urban Meyer-led Florida Gators. And Ohio State ran back the opening kickoff for a quick touchdown, and we thought, boy, here we go. This is going to be a great trip. And I don't think we scored another point that game. If we did, I didn't remember it because I was surrounded by Gators all giving me that Gator chop. And boy, I couldn't wait to get out of there. Hopefully you won't feel that way after I finish my remarks. It's a pleasure to be with you this afternoon. And I will say I'm here from the government, and I truly am here to help. And I hope that over the next couple of minutes with you, I can prove to you why I say that. This afternoon, I'd like to share how, under the leadership of President Trump and Secretary Azar, we are approaching the most significant domestic policy issue of our time, transforming the American healthcare system. America's healthcare system is huge and, as you know, immensely complex. It's too complex. It's the single largest sector of our economy at more than 1/6 of GDP. The Department of Health and Human Services itself employs 80,000 people. So imagine that. I grew up in a town of 13,000, and I thought, we were city folk. Imagine a organization, that would represent a town of 80,000 people. We managed to a $1.2 trillion budget and more than 300 individual programs. I've been there a full 6 months, actually 6 months today, and I'm certain that I still am not familiar with even a half of those programs. But just because we have a complex system and complex challenges doesn't mean that there are no simple principles for reform. One of America's greatest leaders, Ronald Reagan, applied common sense solutions to the supposedly intractable challenges of his time, such as an overly complicated tax code and a bloated, broken welfare system. Like President Trump, he saw through how Washington works and had a pithy description of how problems are usually handled here. Government's view of the economy, in his view, could be summed up in a few short phrases. If it moves, tax it. If it keeps moving, regulate it. And if it stops moving, subsidize it. For too long, in our view, that has more or less been the federal government's approach to health care. We saw it most recently with the Affordable Care Act, which imposed a new tax or regulation, or sometimes both, on just about every moving part in our healthcare system. There was even a tax on not buying the right kind of insurance until President Trump and Congress repealed it. The Trump administration's first instincts are the opposite of the big government nightmare President Reagan described. If something in our healthcare system isn't working, we'll see if there's a regulation in the way. If prices are high, we'll see if there's a tax involved. If prices keep rising, we'll see if there's a subsidy driving them. We all come by these lessons in different ways. Throughout my career, I've seen dozens of well-intended government health policies create the unintended consequences of higher prices, less access, and numerous market distortions. And so, in considering the challenges we face in rehabilitating the American healthcare system, I and my colleagues start by asking, how's the government involved here? What do we need to understand about the role we're playing that's driving this outcome? When things don't work the way they should, when we ask why the rest of our economy is fully digitized and healthcare isn't, when we wonder why healthcare lacks the dynamism and consumerism of the rest of the economy, We look for culprits. So very often, the culprit is right in front of us in the form of a past or current government action. In some cases, that means government action may often be needed to fix what government action broke. Sometimes the necessary government action may be strong medicine, because as much as we believe in a free market approach to healthcare, markets over time have become so distorted or so diminished. And sometimes our solutions may be subject to the law of the second best, to use law and economics speak. Always, however, our actions will be aimed at building markets and competition, restoring price signals and incentives, and empowering consumers through choice rather than having government decide what is best for the individual. Our belief is that a consumer-centered healthcare market defined by robust choice of health plans and providers, each of whom operate in competitive markets, is the best way to allocate healthcare resources to consumers. Today's healthcare market is the result of an historic reliance on third-party, cost-plus, fee-for-service reimbursement models that reward volume over value. We don't believe that a free market in healthcare would have ever created anything like what we have today, and we're determined to replace this model with something that works for American healthcare consumers. Now, that's a great description of our aspirations, but we know that it won't be that simple. We know that these challenges that we face are the reflection of decades of health policy that we can't immediately take action on. Perhaps most importantly or most significantly, because so many of the changes that we would ideally like to make involve congressional action. And we've all experienced in different ways how challenging that can be. But nonetheless, we're doing as much as we possibly can within the scope of our authority, which is primarily at the moment focused on rulemaking and changes to existing government rules to make those improvements. As we consider reforms, we're guided by what we've identified as 5 principles for how we think about adopting change. And I'd like to share with you those 5 briefly. The first is to provide more affordable private market coverage. The second, encourage sustainable spending growth. We know, and we've almost been led to believe, that it's inevitable that healthcare will continue to grow at a rate of increase that's greater than the general economy. We're not sure why we believe that, but we've been led to believe that. We're not certain that that's the case. We want to foster state innovation wherever we can, certainly with respect to our Medicaid programs and commercial markets. We know that we're a large, diverse country, and it's unlikely that we'll develop a national approach that will be equally beneficial to all corners of the country. What would work best, in our view, is to give states and local markets the opportunities to innovate and really be unleashed from federal regulations that inhibit the development of solutions that would work best for those local markets. Our fourth principle is to support and empower those in need. We recognize that healthcare and the provision of healthcare is integral to well-being. We also know that not all Americans are equally positioned to support the financing of their care needs. And so we acknowledge that there will always be a need to support those who don't have those resources. And then finally, and perhaps just as importantly to everything we'll discuss, is promote consumer-driven healthcare. And what we mean by that is wherever possible, putting the patient or consumer back in control of healthcare decision-making. Thank you. So today I want to share with you how we're taking this approach to reforming 2 aspects under our charge: reforming the individual market for insurance and bringing down the high price of prescription drugs. Let's start with individual health insurance. The Affordable Care Act created a thicket of subsidies, regulations, and taxes to help Americans without employer insurance secure coverage on the individual market. In theory, it was supposed to not only expand this kind of private coverage, but also bring down costs. It has come up short on both objectives. According to an HHS analysis, from 2013, the year before the most significant new regulations went into effect, through 2017, a short 4 years, premiums in 39 states rose an average of 105%. They have more than doubled. As prices skyrocketed, it's little surprise then that the real market for individual insurance, that is, the part not supported by the Affordable Care Act's huge subsidies, has actually shrunk. What I'm saying by that is that for those who are in the individual market, trying to purchase coverage without the benefit of a federal tax credit, which draws down the cost of their insurance, those individuals who have to pay for their insurance solely out of pocket have chosen to go without insurance. In fact, the market has shrunk by 20% in the most recent year. That's significant. And I suspect you're seeing that and feeling that in your practices. The only factor keeping the market alive today is the tens of billions of dollars of subsidies that the federal government supplies directly to individuals each year. The fundamental flaw of the ACA is that it narrowed the competition for insurance options and laid down heavy-handed controls on the prices that could be charged. One of the most notable price controls doesn't, I think, get enough attention. In a free market, young people can buy insurance for about 1/6 of what it costs older people, simply because younger people use fewer healthcare resources. But the ACA imposed a price floor. Younger Americans must be charged at least 1/3 of what older Americans pay. This kind of price control chokes off private markets. Young people are by definition getting less than they pay for, so they opt out of the system. And then that's not a good deal for older Americans either. They're the ones left paying into the system, so their premiums rise. We believe the Affordable Care Act has fundamental flaws that can only be addressed through congressional action. But until then, we also have a responsibility to do what we can to make the programs we administer as effective as possible. You may have heard our actions regarding the ACA described as acts of sabotage. In fact, in Washington, that's a regular refrain. Here goes HHS again trying to sabotage the Affordable Care Act, when in fact what we're trying to do is to bring some common sense to how these programs work. However, this charge couldn't be further from the truth. In fact, one of the early actions the Trump administration took was to promulgate the, quote, market stabilization rule. If we are truly trying to sabotage the marketplace exchanges, we wouldn't be implementing marketplace stabilization measures. We've also worked to repair a flawed risk adjustment program struck down by the courts. Far from working to sabotage a program that almost 10 million Americans rely on, we're working to stabilize this program until more fundamental changes can be enacted. In a small way, our work is paying dividends. For the 2019 Marketplace Open Enrollment that began yesterday, more insurers will participate than in recent years, creating greater competition. And for the first time we can remember, the average benchmark premium is lower next year than this year, down by 1.5%. As I've said, Congress created this broken system, and it will take an act of Congress to completely undo it. But we also have the flexibility within the law to adopt free market reforms, and we've done so in 3 significant ways that I'd like to share with you. First, earlier this year, we issued a proposed rule to expand access to short-term, limited-duration insurance policies that are free of the strictures of the Affordable Care Act, and as a result, cost as little as 1/3 the price. The previous administration limited access to these plans in the hope that they could drive people back into the ACA market. Remember, if it's still moving, regulate it. We care deeply about consumers having the information they need, so we've made it clear that these short-term plans aren't for everyone, but Americans deserve all the affordable alternatives they can possibly have access to. Second, earlier this summer, the Department of Labor finalized a rule to significantly expand access to association health plans, under which small businesses and individuals running their own companies can come together to buy cheaper insurance. The number of small businesses choosing to offer insurance to their employees has been declining for years, but getting government out of the way has the potential to help reverse this trend. And just last week, HHS, Treasury, and Labor jointly issued a proposed rule that would allow employers to contribute funds to a health reimbursement arrangement from which an employee, rather than having to leverage the employee benefit that their employer had chosen for them, would have the ability to purchase an individual product, including a short-term limited duration policy, that best meets their needs. So again, in this way, we hope to create a degree of empowered consumer that doesn't exist today. Each of these actions are intended to increase the choices Americans have and the degree of competition that we experience in the healthcare system. Let me now transition to a brief description of what we're attempting to do with respect to drug pricing. And because of the limited nature of what we're able to do through rulemaking, they primarily affect the Medicare and to some degree the Medicaid programs. But nonetheless, they're important and I think symbolic of the approach that the administration is taking and the commitment and the seriousness that we're taking to solving these problems. As you know, the President has called for historic changes to another piece of the healthcare system, our market for prescription drugs. American private industry has produced so many of the world's miracle drugs, like cures for hepatitis C. Today, we're on the verge of stunning advances in the war on cancer through treatments that use our own immune systems to fight the disease. We also have access to cheap, effective treatments through the world's strongest market for generic drugs, which actually delivers us lower prices for many generics than European patients pay. But in some important ways, we don't have a real market for prescription drugs. One fundamental aspect of a market is generally that if you cut your price, more people will buy your product. And yet, that is not, by and large, how drug prices work in America. If a company lowers its price for a given drug, the drug can actually become less desirable vis-a-vis its competition. Obviously, consumers wouldn't look at it that way, but they don't decide which drugs are available and at what cost. This is decided by insurers, employers, and pharmacy benefit managers. This could work well if these parties' incentives were aligned with consumers, but all of them are paid as a percentage of a drug's list price. When prices drop, the consumers might save, but those actually negotiating for the consumer would then make less money. President Trump has put this whole system on notice. We have the power to break up this arrangement ourselves through administrative actions because it relies on a loophole in federal law that allows these otherwise highly regulated entities to, essentially, double deal. Already, we have seen drug companies hit pause on price increases or actually cut prices, understanding that we are on the verge of significant reform. Fixing the broken incentives around list prices is just one piece of the President's plan. But a real market also requires that consumers, competitors, and other private actors are pushing down prices. The three other elements of our plan are, therefore, giving private negotiators more power within our system to negotiate with drug companies, empowering consumers to bring down out-of-pocket costs, and stoking competition in drug markets. Delivering on this plan will involve taking some steps that may be unexpected and, candidly, unorthodox for a Republican administration. It took some by surprise, for example, earlier this summer when Secretary Azar directed the Food and Drug Administration to stand up a working group to examine how importing drugs from other countries could help address patient access problems caused by spikes in drug prices. This shouldn't necessarily have been a surprise because the President was very clear when we rolled out our drug pricing blueprint earlier this year. We're open to all solutions that put American patients first, meaning they're safe, effective, and respectful of patient choice and the incentives that drive American innovation. The FDA will be looking at situations where we have good reason to think importation could fit these requirements, where a company that's the sole manufacturer of a drug in the United States takes a big price increase on a drug that no longer has any patent protections or exclusivities. Because there are no IP rights involved, manufacturers in other countries could help introduce new competition without undermining incentives for innovation. We have long had concerns about how broad-based importation could raise safety issues, but especially within the bounds of this proposal, we believe it may be possible to introduce more competition while keeping our drug supply safe. Thankfully, we do have successful competition and negotiation in parts of our drug markets, including within Medicare, where Part D plans aggressively negotiate with drug companies to keep costs down. Those insisting we must have, quote, direct negotiation, end quote, between the government and drug companies aren't really interested in negotiation. They're calling for the federal government to impose a formulary for all Medicare patients, with no right to choose another option, and use the possibility of denying coverage of certain drugs to drive prices down. That doesn't respect patient access and violates one of the core principles of American health care. In our system, you have exit rights, you have choices. To coin a phrase, the way our system works, if you don't like your plan, you don't have to keep it. We know that we can respect this principle while expanding coverage and bringing down prices because we've done so in the past. Many of you here will remember the complaints during the 2000s that Medicare Part D's negotiation system would be a giveaway to drug companies. But because it harnesses market forces and has driven thriving generic drug competition, Part D has actually come in tens of billions of dollars under budget while providing seniors with the life-saving drugs they need. Let me repeat that, as I know these are words pretty much never heard in Washington. Tens of billions of dollars under forecast, under budget. The good news is that there is certainly room for improvement within Medicare Part D. Some rules stand in the way of plans doing the best job they can negotiating for seniors, and we're reforming them to generate savings for seniors and the taxpayer. One most recent action to lower the cost of prescription drug prices was taken just last week when we issued an advance notice of proposed rulemaking. For those who never worked in Washington, I wouldn't expect that means anything to you. I'm not sure it meant a lot to me either until I had to do my homework around that. But it is most importantly a signal of the administration's intent to reduce the gap in prices American seniors pay for prescription drugs in comparison to the world's other developed countries. Today, Americans pay 80% more for the same drugs on average than what is paid by other countries for the same drugs. Now, we know that in trying to make progress on these issues, oftentimes you have to make bold declarations and signal intent that may be uncomfortable or particularly disruptive to many portions of the industry. But candidly, we feel that we're at a point where bold action is required. And our belief is that if we stay loyal to the principles I've articulated, the 5 principles articulated earlier, that we can, in fact, take bold actions that will be successful. The healthcare challenges I've described, like our largest healthcare programs, are decades old. As the cost of American healthcare has kept rising without commensurate increases in quality, it simply shouldn't have taken us this long to stop talking about fixing them and actually getting down to doing it. Today, fixing American healthcare requires disrupting government-dictated systems, building new ones that encourage, encourage choice and competition, and heeding, as I said, the principles I've outlined for you today. Letting private innovators, like all of you in the room, chart the future and refusing easy gimmicks takes some courage. But it is leaders with that kind of courage who've kept America exceptional. And President Trump is committed to that type of exceptionalism. With an openness to change, to innovation, and to real economic dynamism, we can secure American exceptionalism in healthcare for generations to come. Thank you again for having me here with you today, and I look forward, if we have the opportunity, to taking any questions you may have.
So first of all, thank you very much for those comments. Just a couple questions. I think one of the issues that we get asked as a direct primary care doctor all the time is, we can afford your basic services, we can afford, your primary care, but what happens in the event of a true emergency? And the question was, how do we get some sort of affordable, catastrophic, major medical? Because, frankly, the major medical plans were essentially made unavailable under the Affordable Care Act. And so that's one of the reasons why we were pleased to see the announcement of the changes of the short-term limited duration plan. So do you see that as direct primary care with a major medical being part of this solution, and how do those fit together?
Thank you for that question. We absolutely see what you've described as a part of a larger solution. And unfortunately, that is one of those areas where we likely will require congressional action. Again, with the best of intents, perhaps the Congress established a minimum value that all insurance policies must carry with respect to what they return to policyholders and the degree to which benefits are included in a policy of insurance. But we think that they went too far. And so, for example, in the example you've described, the type of catastrophic plan that someone would want doesn't meet the minimum actuarial value requirements that are in the statute today. So we would like to see those requirements either eliminated entirely or broadened so that someone could do exactly what you've described. Again, our view is that in many respects the Affordable Care Act took a view of healthcare that suggested that the smart kids in the rooms would make the decisions for everybody else. And what our view is that people aren't just as dumb as others would like them to think. And so we'd like to unleash the native wisdom that individuals carry so that they can make decisions that are really in their best interests.
So we do have time for a couple questions. We'll go ahead and take one from
Jim,
this
thank you
microphone
so much for being here today. We really appreciate your comments. And in the last session that we had preceding this, it was a legal session. And a question came up which you're aptly suited, I think, to answer, which is it had to do with the fact that there are many of the doctors around in this room who see patients who are on Medicaid. And although I know that's a state mandated program, it gets guidance from HHS. And so one of the concerns was whether or not someone who is on Medicaid could have a direct primary care doctor and then orders, tests, things that needed to be done, which the primary care doctor would order, would then get covered by Medicaid. How can that be addressed?
No, thank you for that question. It's an important one, and in some respects, I think very timely. I mentioned that one of our principles is to foster state-level innovation, and we think that, in fact, Medicaid is one area where that is ripe for that type of innovation. Within the last 10 days, we issued to the states revised guidance with respect to the types of flexibilities that the government would approve as they administer their Medicaid programs. And so it's just that type of innovation that you've described that we're encouraging the states to consider. We have this view that, there's Medicaid, Medicare, and again, it's only natural that mentally we try to compartmentalize things to facilitate our own ability to understand them and make decisions. But in so many respects, particularly in Medicaid, we have a view that says, well, there really isn't a lot of opportunity to innovate in Medicaid. We just need to make sure that we do everything possible to give those less fortunate access to wellness services, and above all else, keep them out of the emergency room. And, and if we can do those two things, mission accomplished. But that's not, that's not, we feel that's not being true to the opportunity to both serve them in a way that's most beneficial and also serve the needs of the program. So the waiver authority that we issued last week simply hands the baton to the states, but I think there will now be opportunity for you, your colleagues, and others to go to the states and encourage them to adopt those kinds of changes that you've described.
We have time for 2 more questions, and we just happen to have 2 more people standing at this microphone right there. So, Dr. Alida Akin.
Hi, my name is Dr. Alida Akin. My husband and I started a non-government free clinic in New Jersey 15 years ago, and we found that half the people we see are on Medicaid that can't find a physician. So at the cost of about $15 per patient visit, because everybody volunteers, we're able to meet the needs of these people. It's been an extraordinary experience to run this clinic. The Federal Tort Claims Act gives us medical malpractice protection for what we do in the clinic, which has been extraordinarily helpful, and that's through HHS. Thank you very much. But it occurred to us that there's loads of physicians who are not volunteering who would be so helpful from all the different specialties if we could somehow expand that. And so we have a law we're trying to get, a bill that's been written, and we're trying to get it passed in New Jersey, where if doctors donate 4 hours a week in a clinic like ours, non-government, all we'd ask the state to do is to give us liability protection in our private practices. The other possibility would be for the federal government to do the same thing, to give us, extend that liability protection if we are donating a significant amount of time. And we would solve so many of the problems, keep people out of the ER, they'd go to the clinic instead of to the ER. They wouldn't have to call to make an appointment, which they can't find doctors to take care of them. It would just solve many problems in the healthcare system. So I don't know if you have any comment on that.
Well, no, if I understand what you're describing correctly, really the establishment or extension of Good Samaritan laws to apply to time spent volunteering in those types of clinics.
We already get that, but we're talking about doctors significantly donating a lot of time, 4 hours a week, to get liability coverage extended to their private practices.
So that would be the trade-off.
Yes.
I see. Boy. Yeah, I would need to think about that, only to understand it more thoroughly. I will say, and this, you may think I'm passing judgment on your idea. I'm not, but it does remind me of so many of the things that we do across our industry that are designed to be kind of simple trade-offs, and I know this is, perhaps wishful thinking, but wouldn't it be great if our tort laws were more reasonable and we didn't have to, and it weren't such an issue, right?
That's right.
But I'd be glad to learn more about your proposal.
Okay, thank you.
Thank you. And last question, Dr. Hempel.
Ori Hampel from Houston, Texas. I'm sure you've heard the term physician burnout, and this is one of the reasons you're here, is because these are people trying to avoid that burnout and undo that. So one of the big things about physician burnout is maintenance of board certification. So in Texas, we fought and the physicians won a bloody battle to enact a law that maintenance of certification would not be required for hospital privileges and insurance panels, etc. Our biggest opponent were the hospitals. The reasons the hospitals opposed us, and when I say they opposed us, when this was debated in the Texas legislature, the entire balcony was full of hospital lobbyists only, okay? The reason is CMS, because for them to get their trauma money, for them to get their heart center money, the language, the regulatory language that you don't need Congress to fix, says that you need board-certified doctors. If you can do a word search on all of your CMS regulations and find board certification and cross it out, you will make every physician in America love you. You don't need Congress. You just need a pen.
Very good. Thank you.
So, with that, I want to thank Jim Parker for being here. I greatly appreciate his time and making the effort to come down and be here.
Enjoyed it.
Thank you. So, round of applause for